difficult for us to diagnose. So for this, there was an evolution of a diagnostic classification to make it clear, okay, when to give what diagnosis for a TMD patient. So the evolution started from 1992. Okay, they started with a research diagnostic criteria for a TMD. Okay, so in that, what happened is there was pitfalls like it was highly research focused. So it was not at all applicable for the clinical settings. So what happened in 2014, then they decided, okay, we need to do another classification, so which will be easily applicable for a clinical setting, so that everyone, any clinical practice people can apply it and they can come to a particular diagnosis. So DCTMD classification, we have this axis 1 and axis 2. Axis 1 will be dealing with myalgia, arthralgia, disc displacement, degenerative joint disease. That's all. So only these four are the main category. Into it we have some subcategories. Okay. So and then we have axis 2. Along with the axis 1, they are adding this psychosocial model. Nowadays, I told stress is becoming a very important aspect or factor for TMD. So in order to rule out that also, pain-related disability, depression, anxiety, all these are also being questioned from the patient. So classification of DC-TMD, it is evidence-based. So TMD, it's broadly classified into temporomandibular joint disorder and disorders of masticatory muscle, then headache associated with TMD. So TM joint disorder is then classified into joint pain, joint disorder, joint disease, trauma, congenital or developmental disorder. Then masticatory muscle disorder will be like myalgia, myofascial pain with referral, then headache associated with TMD. Now this TMD disorder as such, you can see there are so many classifications, but it's easier to understand. Already I told it's arthralgia, then myalgia, then it will be like inflammatory joint disorders, so it will be following that. So you can say joint pain, you have it as arthralgia, joint disorder is disc disorder, hypomobility disorder, hypermobility disorder. Then you have joint disease, in that you have degenerative joint disease, fractures, and then congenital developmental disorder. You have aplasia, hypoplasia, hyperplasia. So what is the difference between joint disorder, joint disease? Disorder is there is a functional disturbance. For example, all the disc related, there will be normal function is not exhibited. Whereas joint disease, there will be a pathological change will be there. In the condyle, you can see that there will be destruction. So that is the difference between disorder and disease. So what history we need to ask from the patient? So taking proper history is really mandatory for us to get at least 50% of clue for diagnosis. So onset of the patient, usually the pain will be little acute. Then that will be that sometimes there will be a persistent sort of pain. The pain might be deep, aching. So these sort of words they'll be using. It will be little deep and then aching, and then they might be having radiation. I already showed you the different varandole it is referred, and then the associated relieving factors like taking rest, the patient will get relieved from TMD. So the joint usage should be restricted. They should not keep on, for already patient is having pain, they should not keep on using the joint. So the joint should be restricted. So taking rest and giving analgesics, it will settle down the pain. And then jaw function, if we keep on using it, it will worsen. Then what will be the duration? Again I already said, it might be acute or it might be persistent. Diurnal variation, sometimes muscle related pain who is having nocturnal bruxism, parafunctional habits, night time we will be using too much the jaw, and the morning as soon as they wake up, severe pain will be there. So these are all the clues for diagnosing it as TMD. Chewing, talking, yawning, all these will aggravate the pain. Severity, usually it will be mild to moderate. It will not be very severe like, for example, trigeminal neuralgia. So the main confusing is whether it is trigeminal neuralgia or TMD. So the pain for TMD will be mild to moderate only. It will not be very severe where the patient will say that it's really hurting like that. So what and all we are supposed to exclude when we are going for a clinical examination. So first of all, before we say that this is going to be a TMD, you should first thoroughly check a clinical exam or intraoral examination. First to see if any pulpal pathology is there, any abscess. Okay, so first you rule out any periodontal. First, please rule out those things. Do a complete cranial nerve testing, mainly your trigeminal nerve, your facial nerve. Just see if any numbness or a sort of paresthesia, anything is there. And then check for the major salivary gland pathology, if anything bilaterally, parotid gland, if anything is involved. And then intraoral, any soft tissue, any pathology is there, just do a screening. And then check for the lymph nodes also. Then for TMD, you need to do a muscle palpation. Usually it will be a direct palpation or it will be a functional manipulation. So direct palpation will be like we use the digits, we just exert pressure and we try to recreate the pain from them, whether they are having it or not. Functional manipulation, by doing the movements, jaw movement, jaw opening, closing like that, are they having pain? Okay, so other than that, what are the other different types? Digital palpation, we use only the fingers, bidigital, 2 fingers, bimanual, 2 hands. Okay, so what and all will be the degree of discomfort? So usually 0 means there will be no pain, 1 they will be having a sort of uncomfortable. They will be like the comfortable is lost, and then 2 will be like definitively the patient will be having discomfort. 3 they will be tearing, eyes will be tearing with pain. So severe the pain might be. So example for bidigital, you can see the masseter. This is one way of palpating the masseter muscle. Temporalis, all these are, it's not a functional palpation, it's just direct palpation. That is, patient is not asked to clench or do any movement, just you apply pressure and then you find out whether the patient is going to have pain or not. Lateral pterygoid, again, usually it is very routinely practiced in the clinical setup. We use our index finger, we go behind the maxillary tuberosity region, we exert pressure. In that region, if the patient is going to have pain, then we confirm that patient is going to have lateral pterygoid muscle pain. And medial pterygoid, usually, since it is inserting in the medial surface of the ramus of the mandible, the floor of the mouth, in the medial aspect, we can palpate. So functional manipulation, the same thing, I must ask a patient to clench the teeth. So you can see that the temporalis muscle is palpated in the anterior aspect, the middle fibers, posterior fibers, all these are palpated. Masseter palpation, so it is palpated at the deep head and then the superficial head. So it is like the origin part is palpated, the insertion part is again palpated. Sternocleidomastoid palpation, the origin mainly sternocleido. So it is mainly in the sternum and then the cranial aspect will be the origin, insertion will be in the mastoid. So both the region you need to palpate. Posterior cervical muscles. So we have a set of muscles. You can see that there is semisplenius capitis, splenius capitis, ligator scapulae, okay, scalenus muscles. So all these trapezius, so they all play a very vital role. Many patients who are having the system related works, those things, they have a lot of ache in the back region. So that could be the main possible reason for TMD. So we need to check these muscles also. So we have this sternocleidomastoid, we just have to go behind, look for each muscles. It will be layered down, one by one it will be layered. So that also we need to palpate. So how do you palpate the lateral pterygoid functional manipulation? So usually the lateral pterygoid muscle, you need to ask the patient to protrude the mandible. Okay, so when the mandible is protruded and the patient is having pain, then the patient is having lateral pterygoid muscle tenderness. Already we had one thing intraorally, and this is the functional manipulation. Okay, and clenching the teeth also, patient will be having pain. So if it's muscle related, on clenching the teeth, patient will be having pain. Protrusion of the mandible, patient will be having pain. Intracapsular disorders, mainly your disc disorders, usually within the disc there will be a interarticular pressure which is maintaining the disc. So if the patient is clenching, they will be having pain in the disc related disorders, and if you keep a ice cream stick in between the patient, then the pain will be relieved. So this is also one differentiating factor, whether it's a muscle related or joint related. Okay, so muscle related, protrusion of the mandible, and along with that clenching will be aching. Whereas in disc disorder, just clenching will increase pain. There won't be any protrusion of pain in the protrusion of the jaw pain. So TMJ examination, it will be intra-auricular, it will be pre-auricular, and stationary movement like mouth closing, and then we do mouth opening palpation also. Maximum mouth opening, we need to check for the maximum mouth opening. When do we use this term deviation and then deflection? Deviation will be like, there will be a S-shaped curve, okay, and deflection will be like straight away, it will be mouth closure will be in the opposite direction, okay. So ADD with reduction, so that will be deviation, and ADD without reduction, that will be deflection. And lateral movements, yes, that also we need to check for the midline shift, okay. So how much is the lateral movements patient is able to do. So usually, normally, if the patient is having no TMD, 8 to 12 mm is normal. Anything lesser than that, then the patient is going to have lateral movement problem. Then end field, you need to have know this terminology, end field. That is patient, you have to check for the mouth opening, whether how much he is able to comfortably open the mouth, how much maximum he is able to open the mouth, that also you need to check. And assisted mouth opening, how much you are using your hand to open the mouth wider. Unassisted, how much without any this thing he is able to open the mouth. Hard end field, that is when you are assisting the mouth opening, you are not able to open the mouth, so that will be hard end field. So that will be present in ADD without reduction, because patient will be having restricted mouth opening. And the smooth end field, where there will be restricted mouth opening, you apply pressure, you are able to slightly open the mouth, so that will be muscle related. So muscle related, you assist the patient, you are able to open the mouth. Disc related, patient is not able to open the mouth even if you are going to assist him. So it will be a little harder, it will be disc related. So what are the signs and symptoms of TMD? Usually extra-auricular patient will be having pre-auricular pain, tenderness, there might be hypermobility, there might be limitation of the movement, joint sounds, clicking, popping, grating. So all these are the terminologies used. Deviation, deflection, then inability to open the mouth, inability to close the mouth, and masticatory muscle tenderness. Intra-aurically, you need to check for the midline shift, check for the deranged occlusion. Occlusion, how is it? Whether the patient is having missing teeth or any malocclusion, any debite. So everything has to be checked. And then bare facets, if any parafunctional habits are there. And then position of the third molar. Nowadays, many patients with third molar impaction, they are getting TMD problems. So that also have to be checked and palpate for all the muscles of mastication. So management of TMD. So all general things which is present in literature I am saying, then I will go case based. So whatever therapeutic management, always for TMD, best go for a non-invasive treatment. Initial treatment which you are giving, go for at the maximum a non-invasive and a conservative sort of treatment. Don't go for something which is going to alter the jaw totally, alter the occlusion totally, or going for a surgical procedure. Okay, we can do, but at a last end where the patient is not getting any benefit from the medical management, then the last option we can go for the invasive procedure. So you have a set of conservative management procedures like exercise, medications, physical therapy, appliance, then we have biofeedback. So try to avoid the irreversible therapy. So initial visit, don't go for too aggressive treatment. All initial treatment should be only conservative, reversible, and it should be non-invasive. And there are two types, definitive therapy and supportive therapy. Supportive therapy will try to reduce the symptoms. Initially when the patient will be having severe pain, you can reduce it. Definitive therapy, sometimes they need alteration of the etiological factors, mainly your stress, or even supportive therapy will be for a shorter duration. You need to identify it, what etiology is causing that. So that has to be identified, and then we need to curb that. So if it's going to be because of the occlusal parameters, then we can go in for a reversible occlusal therapy like a stabilization splint. So it will mainly help in maintaining the occlusion, the orthopedic stability. So those will be like, they can reduce the parafunction habits, the stress levels, nocturnal biting. So all those things can be reduced. This is irreversible occlusal therapy, mainly given for ADD without reduction, where the disc is totally deranged. So it is more anteriorly present. Thus, in that condition, if you give this one, so it will be helping in guiding proper occlusion. It will be helping them to mainly reduce the pain. So this will alter the occlusion. This should be given only for a shorter duration, mainly 3 months, that's it. Don't give more than that, it will alter the occlusion totally. So mainly, very important, emotional stress therapy. So this actually nowadays is very major role which is contributing to TMD. So if you could see, there are so many personality traits, so many patients, they all are different. So you need to sit and talk with the patient, the history, so what sort of family issues they are having, whatever it is. So you need to identify what actually they are suffering from. So you can see that the patient are, some patients are very perfectionist, some they are very compulsive, some they are very introvert, some they are very anxious. So these group of patients, they are saying they are suffering from TMD. And common emotional states like short term and long term, like anxiety. Anxiety is like fear for anything, and apprehension, frustration, and depression will be like if like they will think as if everything is lost. For a longer duration, they are suffering from anxiety, that will become depression. So for all these things, treatment will be like reversible occlusal therapy. We can give them CBT, that is cognitive behavioral therapy. So that will, I'll be saying what it is. And a low dose of TCA, tricyclic antidepressants. So that can be prescribed. And patient, main thing is like patient education and reassurance. Many a time patient who are coming with TMD, more than the psychological thing, whether the TMD will get treated, that itself is a big questionable thing for them. So that itself will create a lot of stress for them. So we need to give reassurance for the patient that this is treatable, and with follow-up, this can be definitely managed. So evaluating the emotional stress is very difficult. Doctor-patient relationship, that is very important. So you have to give reassurance for the patient. Behavior, you need to modify it. Whatever behavior they are having difficulty, so you have to modify it. Psychologically, we need to modify them. So all these things, training will be given by the psychologist. So education and cognitive awareness. First of all, the patient should be made aware that because of the emotional stress, what will happen is their HPA axis is little sensitized. So because of which their main action will be, it will come and result only in the muscle. So muscle, what will happen? There will be hyperactivity. Because of the hyperactivity, they tend to clench. So you must make sure that there is stress. So because of that, you overusing the muscle. So how that overusing will come? Teeth is coming in contact. So that awareness you should create to the patient, that please do not contact your teeth. Contact of the teeth should be done only during chewing, speaking, swallowing. Other than that, any contact is going to derange your occlusion. So this thing first we need to give awareness to the patient. Okay, so avoid any tooth contact, chewing, speaking, and swallowing. So first visit, if you say this, second visit, definitely there will be a change in the patient. They will come with some altered response. Cognitive behavioral therapy. So many patients will be suffering from this. Their situation, work pressure, so work stress. So what happens automatically, the thought gets disturbed. So I'm not good enough, like that. And the emotion, they become worthless. I'm nothing. I'm totally worried, feared, and behavior gets changed. They contact with other social people, everything will get changed. They will not contact anyone, and because of which what happens, the mind is stressed, and they feel tired, there's loss of appetite and everything. So here the treatment will be given by the psychologist. There will be sessions. So when we identify this, then we can refer the patient to psychologist. So they will be giving sessions. They will give coping strategies. Like the patient will be having some past events. So that will be identified by the psychologist, and they will see to it that patient will have only positive thinking. So all the negative things will be, they will try to inhibit it, and only positive thinking is given to the patient. Because of that, there will be repeated exercises. So it will make the patient somehow get trained to the positive thing, and they will try to prevent all the negative attitudes and behaviors. So if their lifestyle become different and they get changed. So restrictive use, again patient who is having pain already, they should not overuse it. I already told, they should eat only soft diet, small bite only they should take. They should chew very slowly. So these are the main things the patient has to follow. Soft diet, small bites, chew slowly. Already the patient is under pain, so adding again and again, adding more pain, giving more force to the jaw is problem. Voluntary avoidance. So already I told, avoid all the tooth contact. So you can ask a patient to do this exercise like puffing air, blowing air. So see to that the teeth is not made in contact. So they have to do it as an exercise. And the tip of the tongue should not be forced against the palate. Again, that is also a stressful thing. So that also, so see to that, and everything is not like only the teeth should be contacted during eating, speaking and swallowing. Relaxation therapy. So you have the CBT based audio practice, wherein every 20 minutes for 6 to 8 weeks patient can do this. Like the audio will be there and the patient, audio will be playing, making the patient feel calm and they are stress free. So the main thing is that the muscle should not contact too much, it should not be overactive, and the teeth should not contact. So that is the main thing. So repeated, there will be instructions given through this audio to the patient. Attention to your jaw is given, see to it that the teeth is touching, then small space should be created. So silently, the patient then have to, they will say, I can release the tension, I don't need to hold this tight like that. So the thing is that the muscle tightness should be will be relieved by listening to this audio. And biofeedback. So some electrodes will be placed on the patient system, it will be connected, and the muscle activity. So that will be, if the patient is clenching, that will be a peak. The patient is not clenching, the peak will get reduced. So the patient will monitor it visually, the monitor, and so that will be helping the patient to reduce it. So it will be a feedback. So if he is clenching, there will be a peak rising, and if he is not clenching, so automatically on seeing it, he will correct on his own. And then negative feedback is like while he is sleeping, again a ringing bell will be there. So that is also helping the patient. And main thing, behavior modification. So patient should be like educated to go for have a proper sports and then hobbies and then regular exercises, progressive relaxation therapy, and then hypnosis, meditation, yoga. So all these should be there in their normal lifestyle modification should be there. So this will be helping them to modify their this thing. What will be a therapy consideration for trauma? If it is going to be a micro trauma, definitely a definitive therapy like stabilization, mainly your micro trauma, actually that repositioning splint, so that should be given. And for macro trauma, it is a supportive therapy, a stabilization splint can be given. Parafunctional activity, already I said diurnal, usually there will be nail biting, lip biting and those things, and then nocturnal it will be bruxism. Supportive therapy, yes, so this is very important. Pharmacological, always it's better we go in for a pharmacological therapy as well as physical therapy together. So we have a set of pharmacological agents. So what we should be aware of is like, we need to know the proper dosage, we should be knowing where it has to be indicated, where it has to be contraindicated, what are the adverse effects. So many of the TMD will be like, it will be like not going within a week's duration, it will be periodically occurring, and sometimes we might be prescribing narcotics and anxiolytics, so we should be knowing when to prescribe that. And then if you are prescribing an NSAIDs, it has to be prescribed for a particular duration, maybe within say 7 days to 10 days. More than that, it should not be prescribed. So these are a set of analgesics which is available. The main thing which we commonly prescribe will be acetaminophen, paracetamol, 500 mg. Now, other than that, ibuprofen, ketoprofen, all those things are there. And we have this combination ultrasound. The patients having very severe pain, there may be a tramadol and acetaminophen. But tramadol, since it's a narcotic, we should be really very careful in prescribing the this thing, tramadol. It will be only for a shorter duration. Then we have anti-inflammatories. Mainly, this is very commonly prescribed in the clinical practice, NSAIDs, mainly your acetaminophen, aceclofenac. So that will be helping them to reduce their pain symptoms. Other than that, ketorolac, they say very severe pain where the patient is not having bearable, then ketorolac can be tried only for 5 days. More than that, the ketorolac should not be used because it has got risk for cardiac and other kidney diseases. Then we have muscle relaxants, chlorzoxazone that is being used and tisonidine, all these are muscle relaxants. Then few patients respond well for this baclofen 10 mg once. So where they are having very severe muscle related pain, so this can be tried. And anxiolytics, patients when they have identified patients going to have stress related, then we can go for this alprazolam. Okay, Alprax 0.25 mg. But the main disadvantage is that it is like little addictive and it is like little dependence oriented. So better not to prescribe this. Other than that, we can give this amitriptyline. So that is good actually. Doesn't have any addictive effect, but gives a very good action. It is a norepinephrine serotonin reuptake inhibitors. So that is very good for the patient who are not having sleep, they have disturbed sleep patterns. So we can give a course of this, so we can reduce, we can bring back a normal routine sleep, and then we can treat our TMD sort of issues. Then gabapentin also can be tried. Very longer duration patients having pain, chronic pain, then we can try this gabapentin also. You can inhibit at the neuronal level. Other injectable medications, LA can be given in the trigger point injections are there. So you can just give this LA, 2% lignocaine. In osteoarthritis or rheumatoid arthritis, we can try this betamethasone as an injection. Then disc displacements, these and all are very chronic, where we cannot able to manage by the symptomatic management. We can go in for all these as a last option. Disc displacements, arthrocentesis can be tried, and along with it, sodium hyaluronate. They say it's very good, and ketorolac for very acute pain. Topical medication is in and out used, so for the patient because of very lesser side effects and targeted to the particular site. So lidocaine 2% gel, then diclofenac gel, and then fludiprofen, capsaicin. So all these are very beneficial for the patient. You can try this as a first hand, then you can go for the systemic treatment. The physical modality, we have heat fermentation, cold fermentation, which we can say to the patient. Along with this, we can give the topical medication. So that is working really very good. And other than that, to break the trigger point, we can use this coolant therapy, fluoromethane spray. So that is very effective. Then iontophoresis, all these are like little literature based and theory based. So it is like iontophoresis is like you give a topical medication and a low level of current, so the TMD pain goes. Ultrasound, again ultrasound is like it is a frequency sound, so it will be going little deeper, so the deep pain, so that and all is little chronic sort of pain where your medication is not at all responding. So those can be tried with this ultrasound. That gives actually a good relief for the patient. A little, he has to come for some 3 to 4 sittings. Then I think this will be good. And the TENS is actually like little mild electrical sort of induction will be given to the peripheral nerves. Okay, continuous induction. And so these all are the modalities. So these will be the patient on his own. After you educate, we can help, he can do actually sort of little exercises. Soft tissue mobilization, he can do massage therapy, he can apply the topical medication, give hot fermentation, cold fermentation, and massage. Okay, so that will be helping in relieving any trigger points or something, so that will be more beneficial. Sometimes in the chair side, the anterior disc displacements, so that we can slightly, we can we can just give some pressure over the mandible, we can distract it. So while doing this, because ADD with reduction or without reduction, the patient will be having restricted mouth opening. So because of which little bit if you distract it, the patient will be able to open the mouth. And little patient oriented exercises, like you can ask a patient to passive muscle stretch can be entertained. You can look at the mirror, and usually his jaw will be deviated or deflected. By looking at the mirror, the patient can train himself how to open his mouth without any change in the deviation.